Welcome to Jumpstart Capital's Market Insight event. Today we'll be listening to industry leaders talk about what they're looking to improve in the next 6, 12, 18 months.
I'm going to do a quick intro about Jumpstart and then introduce the panelists. So Jumpstart, I've been a VC for 21 years, been working to bring innovation to healthcare. We all know the healthcare industry needs to be redesigned and updated. We spend about $3 or $4 trillion a year with not great outcomes. For years, the incumbents have been, kind of wanting to make a change, but also resistant somewhat. The Silicon Valley culture of sort of moves fast and break things that Zuckerberg was the original quote. I don't think it really works when human life is at stake. And so in 2015, I co-founded Jumpstart to really flip the process on its head and try to listen to the industry about where and when, what challenges they needed to be solved, and then try to bring that to them. As we begin 2022, COVID has really catalyzed the demand for innovation, where the industry is now clamoring that is really hungry for innovation. I think three factors are driving this. First is the labor shortages are dire in healthcare. There simply aren't enough people to operate the business, and we need workforce solutions, we need workflow solutions, we need them quickly. Secondly, telehealth was rushed due to the pandemic, the public safety. We sort of quickly rushed to offer telehealth, and everyone has been happy with that. And we're looking for the next solutions to make it easier for patients, easier for clinicians, less expensive for payers. And lastly, I think the pandemic showed the importance of public health and wellness really across our population, how important it is to get everyone access independent of income, social status. So the industry is ready, really asking for innovation, but it needs help. It needs help from innovators, from entrepreneurs, bringing them solutions. It's pretty chaotic in the startup world. So at Jumpstart, we're trying to connect the two parties together, and we see this event as an opening salvo and sort of helping people understand what industry leaders are looking for in the next 12, 18 months. And then hopefully innovators can bring solutions to bear that really make a difference. And so I'll do a quick introduction of the panelists. Stacey Chang is here. He's the founder and executive director of the Design Institute for Health, which is a collaboration between Dell Medical School and the College of Fine Arts at University of Texas. It's really a first of a kind institution dedicated to applying design approaches to solving systematic healthcare challenges. He's working with stakeholders from around the health ecosystem, really start harnessing the university resources, and the Institute focuses on that design thinking, bringing human-centered solutions to the clinical and also the greater community there in Texas. Before he joined Dell, Stacey was managing director of the healthcare practice at IDEO. Mike Thompson, second panelist, is the president and CEO of the National Alliance of Healthcare Purchaser Coalitions. This National Alliance consists of about 50 purchase-led coalitions, and they support 1,200 or so groups and have coverage that, eventually responsible for 41 million Americans. So somewhere 10 to 12% of the whole population of the country is kind of in this group that Mike helps manage. Their mission is to empower the purchasers to drive innovation and really make a difference for their companies, the communities those companies work within, and the overall health of the country. Mike previously was a principal at PricewaterhouseCoopers, and he specializes in healthcare and sort of helping employee benefits get structured and implemented. And then we have Tom Olenzak. He's been with Independence Blue Cross for 10 years. He's the managing director of corporate development and strategic investing. Independence Blue Cross is about a $10 billion health plan in Pennsylvania. And in Tom's role, he's responsible for leading corporate strategic investments as well as investments in funds. He manages an existing portfolio worth several $100 million. Previously, Tom was a VC himself, and he remains a central player in the entrepreneurial community in and around Philly. So our plan is we're going to have three different topics of interest. We'll try to move pretty quickly, describing what is working and what needs to be done. And I'm going to sort of tag team this with Steve Tremitiere. So Steve, I may hand it to you to introduce yourself in a second, and then we'll jump into the topics. The idea is that we'll spend 15 minutes on each topic, and we'll have time for questions at the end. But go ahead and type questions into the chat or the Q&A tab on Zoom, and we'll try to monitor as we go. If we can work it into the discussion, Steve and I will try to monitor the questions, but then we'll have time at the end too to look at the questions. So with that, Steve, you want to introduce yourself and then do the first topic?
Sure. Yeah. So very briefly, Steve Tremitiere, partnered up with Vic, and also have been very involved in both the investment and the innovation side of the health space. And my personal mantra is looking at how to accelerate meaningful health innovation, both in the U.S. and globally. And so we also, by the way, just a little housekeeping thing, because we started late, we're going to work to try to still fit within the hour. But the panelists, I believe, can stay over a little bit. So, we're going to try to still get all of the content in. We may have to shrink the Q&A portion at the end. So the first area we're going to speak about is health equity and access to underserved communities. And anyone who's in the health space knows that this is an area which is really finally starting to get the attention that it deserves, not only because it's the right thing to do, as health is a fundamental human right, but it's also critical if we're going to start to make real headway on tackling the huge challenges that we face in the healthcare space. Because oftentimes, in general, it's those populations who have the least access and who face health inequity who are most in need of care and who end up costing the most over time. So what we're going to ask, this will be our format, we're going to ask each of the panelists to take just a minute to talk about, to give us a quick overview of their perspective of this topic, but then to speak specifically to a success story that they've seen thus far in this space as it relates to value-based care, and then also a goal that they have for 2022 that they believe is achievable, since we're really trying to focus on action and not just talk today. So, Tom, you want to take this one first?
Yeah, sure, happy to. Thanks, Steve, and thanks, Vic. So, I guess I'll start out by saying that the whole question of equitable health or health equity is something that's really important to Independence Blue Cross. The overall theme of the strategy that we're going into is what we're calling equitable whole person health. And the idea behind that is obviously the equitable piece is really talking about equal access, being able to be friendly, being welcoming and providing access to all of our members, regardless of financial condition or anything else. And then the concept of whole person health is, and I think we'll touch on this a little bit later, but is this idea that we can't continue to treat diseases individually, that we have to look at the situation involving the entire person. And then it plays into health equity in that we also start looking at the social determinants of health. So really thinking about not just what happens when the patient is in the doctor's office or they're actually receiving care, but also what's going on in their life overall, and how does that impact their ability either to access care or, frankly, the ability for the healthcare system to provide care to them and for them to accept that care. So this is very critical to us. As we look in the past, one of the things I think that's important that we do a lot of thinking about is that equitable access to care is really, it's not just the ability to get to doctor's offices, and it's not just one single magic bullet, if you will, but it's the summation or the total of a lot of different small initiatives. And one example that has actually worked very, very well for us, which came out of actually one of our innovation efforts when I was running innovation, was this concept that you have to meet members where they are. You have to be sensitive to and understand their cultural and financial and other backgrounds before you can really engage with them, or more importantly, they'll really engage with you on their care. And a very sort of simple, example of this is something that we did actually a number of years ago. is we realized that as we were just enrolling members, getting people to sign up for insurance, getting them insured, especially under the ACA, different cultures really think about health very, very differently. For instance, the Hispanic community in Philadelphia, for them, healthcare is a family event. It tends to be a multi-generational, conversation. Whereas I know certainly in my family, I'll sign up for it and everybody will say, oh, that's our insurance. That's nice. But we looked at the way we enroll people, and we even looked at the design of our service centers and realized that if we were going to involve a family, you can't pull them into a cubicle with a chair for the person taking the application and a chair for the prospective member, and that's it. That you had to recognize that there was that generational conversation, that you would actually be dealing with multiple people. So it's a summation of these very small things that add up to access to health. Looking forward, I think one of the things that we're really excited about, one of the projects that we're working on, obviously getting a little more in depth from the healthcare side, is access to maternity care. So if you look across the maternity journey as a whole, there are, and I think we're all very familiar with the stark differences in the care you get, based on, right across town, based on the zip code in Philadelphia. The estimated cost of of having a baby is radically different, to the insurance company, and the outcomes you get are radically different. So we are looking very carefully at how that maternity journey occurs. We're working with our value-based partners in experimenting with different ways to use things like telemedicine, to use things like virtual care, to use things like in-home care, and figuring out how we tweak the reimbursement model and the care model to be able to incorporate those things. Because, frankly, somebody who works 9 to 5 isn't going to, in a remote section of the city, isn't going to have time to get to Center City, Philadelphia, to check in at Penn, for example, pay for parking for all the visits we're asking them to do. But if you can make it easy, make it community based, make the interactions with people they trust, you get much, much better outcomes. And this is part of a much larger strategy to really impact that access to quality maternity care, which obviously has a major impact on cost, both for us, obviously, at the end of the day, but also for our value-based partners, and thinking about how we can help evaluate and make technology available to let them practice under their agreements. So I'll stop there.
Okay, great. Thanks, Tom. Stacey, you want to take that one from the health system
Absolutely. And I'll build on a phrase that Tom just mentioned, which is about meeting people where they are. I'll share 2 market solutions that I think are interesting success stories. They're nascent. They're not done yet, for sure. But the 2 I was going to note are City Block, based on the East Coast, and Walmart, and the 2 pieces of work that they're doing. And you can delve into their offers, which are combinatory, right? Primary care, behavioral health, social services, that's City Block. Walmart adds vision, insurance registration, a pile of other things, dental, and the like. But what's common to both of them are a couple of principles. One is they're serving as hubs. So City Block's doing it intentionally in high density neighborhoods in New York and DC and other places where they can build a hub that's convenient to people, literally on, it's in the name, City Block, right? It's on their City Block. Walmart is a hub in the complete opposite direction. Like, they're the one place in most rural places where everybody goes, right? And so there's a convenience and access for people who are tremendously underserved. And in both cases, they have enduring populations. I don't mean that necessarily from a positive sense. For City Block, they focus on dual eligible. People struggle to move out of poverty. And so they can make investments in the long term that actually pay out, which gives them a longitudinal experience and opportunity with their patients. In Walmart, those rural folks don't really move out either, and they have a long enduring relationship with them. So that's what I'd say I find encouraging, as we see the aggregation of services in a place convenient to where people live. I'd love to see that venue move even closer, which means into home, right? And so whether that's virtual or in-home services or in-home delivery or monitoring technology or any of those sorts of things, right? Convenience is not just about easy, it's actually about access, right? Like, for those who have to take, like Tom said, if I've got to take 4 buses or I've got to pay $20 to park at Penn, like, that's not accessible. That is actually inequitable. And so as we think about underserved populations, that's the thing to keep front of mind.
Fantastic. And it looks like we've lost Mike, but he's back now. Okay, there he is. All right, we'll just wait for him to connect here. And obviously there's an awful lot. Mike, I'm going to go to you as soon as I know you're connected. Okay, Mike, you there? Okay.
I am. Can you hear me now?
Yes, we're challenging all of the boundaries of the virtual world here. So you still there?
I am. Can you hear me?
Yes, we can't see you, but we can hear you, and we'll go with that for now.
Okay.
So obviously what both Tom and Stacey are really highlighting is the access component of this. Can you speak to this from the perspective of the employer?
Yeah. So health equity, frankly, is a relatively new way of thinking for employers. When we look at employers that have been at this, they're kind of in the they start with a mind share around we treat everybody the same. And I think it's over the past year where there's been an increased awareness in terms of the variation that employers experience within their populations, and a more holistic sensitivity to a lot of issues that Tom and Stacey addressed. When we have gotten into, we had a project with the CDC around social determinants. And when we got into those issues with a series of employers, one of the employers really took it to heart with an eye towards not as much social determinants, which is really about investing in the community, yada, 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 but really around the social needs and social risks of their employees. And indirectly, that does lead to more investment for the employee experience within those communities. And in that instance, they have gotten involved again in the issues around transportation and food deserts and things like that, with solid action plans, working with local management and working with internal groups that help them understand out of their experience. From our standpoint, we think the health equity agenda is broader than that. And it's not limited to social needs, social determinants. It looks at variation in healthcare quality and whatnot. And so we have a framework that we're going wide with that includes 4 components. Understand differences. Again, you'd think that would be a given, but it's not consistent. And frankly, we sometimes have a hard time getting the right data to actually evaluate differences. The second is to integrate it into strategy. And that's across the entire spectrum, no matter what interventions we're looking at or what incentives we're applying, how does it apply to subsets of our population? The third, though, is supply chain, what to expect of the people who work for us, the intermediaries, the vendors, and to raise the bar on that with an equity lens. And then finally, this orientation towards building a culture of inclusion going forward. So we're integrating equity into how we manage things.
Fantastic. And I made a note, Mike. I'm going to ask if it's okay to share that framework, because we can send a follow-up out to all the participants where they can get a chance to take a look at that, because I know there's some great info in there. And I think there's also some data that both Tom and Stacey can provide that we'll be able to share with everyone afterwards as a follow-on, since we could just focus on this topic, obviously, for a few hours. So just a quick discussion around this topic. I mean, this is such a huge topic, but the theme that keeps coming across, and I see it also asked about here in the chat, when we talk about meeting people where they are, and both Tom and Stacey, gave examples of really place-based healthcare now, right? Which is, we've gone from, a hospital to something in your neighborhood, or maybe even, something where you have more access. But how do we go to, and I'll open this up to any 3 of you, there's so much of an emphasis now on home-based care, right? And hospital at home. How do you deal with the challenges of, and when you're talking about underserved communities, to be able to get down to the level of home-based healthcare when you're talking about driving that, that last mile, or that last, the last 10 feet into someone's house? Whoever wants to address that one, go ahead.
I'm happy to jump in from the health plan side. And yeah, this is a critical point is we need to meet people where they are to be able to provide health, but at the same time, recognizing that fragmentation of care is a huge issue. We're doing a lot of work in kind of looping back to almost looping back to our topic here, is in value-based care. So part of what we're trying to do is really align incentives and make sure that our health provider partners are part of the decision. So we no longer look if somebody's getting home care, for example, we no longer want to make sure they get the cheapest care, but because the providers are on the hook partially or at risk, somewhat at risk for the outcomes on the care, make sure the providers are actually involved in choosing where and how that care is given. So it means working more closely with our providers. The other thing that we're trying to do, and this is, as everyone's aware, a huge challenge in healthcare, is being able to aggregate data. And frankly, as we look forward and see where, and this is my personal opinion, but the health insurance company is a party that's in a great position, especially within a geographic area, to be able to be that aggregator of data and be able to make sure that data is transitions with the patient as you go through those different transitions in care. So something that I think we all have to think about, not just shifting risk to providers, but also being able to equip them with the data and the tools they need to be able to accurately deliver across what's still a pretty fragmented care ecosystem.
Yeah,
I'll follow in behind Tom on that one. Someone asked me, not so long ago to describe what systemic coordination of care looks like, and I replied, "That's an oxymoron. It doesn't exist." Right? There is no coordination across a fragmented system that consists of entities that don't all answer to the same authority. And so it's actually a massive opportunity, but not in the grand scale of the system at large, right? You actually have to pick out components where coordination actually benefits the player who has the greatest stake. And so if you look at, well, harken back to City Block into Walmart, for example, Walmart not only has the time and attention and has both the attention and the traffic from consumers. It can aggregate a role as a coordinator at the system level for those people because they're always there. They benefit from selling them merchandise in addition to health services. You have to look at, from a market savvy standpoint, of who has the possibility of playing the role as a systemic coordinator and lean into that. And that's not always the case, right? Like, there isn't a single entity nationally who we could point to, but in certain pockets and certain demographics and certain sort of regions and certain sort of, so we could actually identify someone who could do that on behalf. And I think we have to start building from there.
great. And Mike, you want to add to that, and we'll round out this topic?
Yeah, just quickly, I think obviously virtual care has been revolutionized during the COVID period. And I think it actually does improve access in a lot of ways. I think certainly inner city and rural are two good examples where that is happening. I think the concern, is that we put all our eggs in that basket. And I think it's always going to be a hybrid system, but much more enabled. The good news, I think, as we move towards more virtual care and virtual experience as part of care, is that it does lead to the opportunity for greater standardization of metrics and tools that can be brought into the care process that might otherwise get lost in a highly variable system. And so, again, I don't think it's an either or. I think increasingly that experience will be integrated into the broader system.
Fantastic. All right. Thank you for that, guys. Vic, I'm going to turn it over to you for the second topic.
Yeah, great. So it's just listening to that first topic, I agree we could have gone on for a long time. It strikes me that innovation in health, or bringing better solutions to health, there's no silver bullet. Like, there's no one thing that is the whole thing. But it's also not a real technical challenge. Everyone was talking about it's more sort of getting to systematic coordination or maybe aligning interest. There were several people talking about kind of understanding the patient or the other stakeholder, maybe the clinician, where they are, how to align incentives. And the second topic is, I think, related to, it's all related to the same, but which is we really need to begin looking more carefully at prevention and screening in our healthcare system. There's been several studies, depending on which one you pick, every dollar invested in screening and prevention leads to $10, $15, $20 in savings and a healthier population. And so, Mike, I might start with you this time, but in the employer segment, maybe talk about something that has worked really well in prevention or screening, and then something that's a goal for the next maybe 12 months or 12 to 18 months.
Yeah, so in general, the system has defaulted to being much more relied on specialty care and recovery care, if you will, dealing with treating the illness rather than a more longitudinal relationship-based, primary care-based element. Organizations that have focused more on primary care have had big paybacks in terms of downstream costs and also the opportunity to influence referral patterns that can happen downstream. And so we see more of that happening. I think as we look forward this next year, there's a lot of repair that needs to be done as a result of the pandemic itself. The lack of trust, lack of engagement with the system, even things like vaccination generally, not limited to the COVID vaccine, are concerning. And I think employers do believe that if you invest upfront, you will get that payback. Obviously, it depends on the nature of the industry, on turnover and all that, much like health plans. But I think you're selling to a willing audience generally, who wants to invest in prevention as much as they want to recognize the downstream costs.
So, Mike, you touched on the churn and how long an average employee lasts, different by different type of businesses. Do you see that some businesses are willing to invest more and some others based on the churn?
Yes, absolutely. So, the industries that tend to be less inclined to do so, and I wouldn't say it's universally less inclined to do so, would tend to be retail and high turnover type industries, because they keep their employees on average maybe a year or something, right? Whereas certainly manufacturers or longer term type employers, and frankly more people centric technology companies or professional services, will tend to invest in those employees with a longer sight. And frankly, employers tend to have a longer time horizon than even plans do, because they tend to keep their employees longer in those type of industries than plans will with the normal churn in the market.
Yeah. So maybe Tom, take that next. I mean, as a payer, how do you think about prevention, or what has worked well and not well? And the time horizon, although someone might be on Independence Blue for a long time, it also changes every year in a little bit. So how do you think about that?
Well, I guess there's in terms of the churn, I mean, it's always something that you hear from health plans that, the average employee or the average member, is only with you for a couple of years and then churns out, and all of a sudden Aetna, gets the benefit of the prevention work that we've done. I think one of the things that we've really been focusing on is, again, I talked about aligning incentives, the idea of transitioning to these value-based care arrangements. The physician-patient relationship tends to be much more persistent, much more long-term necessarily than even the physician or the patient or the member health plan relationship. And so as we can successfully move those incentives, we can, really drive much more adherence with these various types of preventive services. One of the things that we've done that has worked really well, we have a subsidiary company called Tandem Health that we formed. Oh gosh, I guess it's been about 5 years now. Time flies. But basically what Tandem does is it works primarily in the greater Philadelphia area, but it recruits, so it signs up physicians, independent physicians, and helps them negotiate and also deliver on value-based contracts, value-based payment arrangements. So as we're trying to move more of our population into these arrangements, Tandem is really an enabler. You think about it, a lot of the infrastructure, a lot of the expertise, and a lot of the technology that you need to really successfully implement value-based care is not something that an individual physician's office really is equipped to identify and to install. So we can, help enable them that way. And a big piece of that is making sure that we, the physicians use that relationship to get their patients to, take this care, or to do the appropriate screening and preventive services. And we used to do a lot with incentives and things like that, but frankly, the work required on the behalf of the physician to track down where their patient got her mammogram, was made it very, very difficult. But when they're on the hook for the overall care, it makes it much easier to track that and make that happen. Going forward, and you can see how something like a Tandem could really incent and equipped primary care physicians to drive usage of screening and preventive care, and that's awesome for our population that has primary care physicians. As we look forward, and again, this is part of that theme of health equity, is we're looking at the vast populations that don't have a primary care physician relationship. And we've all seen the statistics on that. But it's both people who either just don't know enough or don't have access to it. And it's also people, especially if you look at the kind of millennial and younger generation, who just have never really developed that relationship. When you're 25 and healthy, you might not even think about it. So we're starting to think about alternative ways, whether it's home-based care and different models of home-based care, or utilizing things like urgent care centers as partners to be able to essentially create that relationship. Again, the challenge that we all have there, is that continuity of care. So if I show up at a Minute Clinic with a sprained wrist and don't have an attributed primary care physician, we can have that urgent care become that primary care physician, but then they don't have any of the records or any of the continuity of data that they would need to say, oh, and by the way, you need to have a name your screen done. Let me help you do that. So there is in addition to the incentives and the compensation arrangements, there's also again, we get back to that data question.
Yeah, interesting. So, Stacey, let me come to you and try to weave in a question from the audience. So, as the health system, and there in Travis County, I think Dell Medical is the main healthcare system. There might be others. How do you think about both your patient population and the broader population? How can you get them into screening? Is that a role of the healthcare system, or how do you think about these issues?
Yeah, it absolutely is a role for the healthcare system. Dell Medical School plays a pretty significant role in the safety net in Travis County, which is where Austin, Texas is located. But I'm gonna share a provocation that's a little bit inside out, actually. So we know it's a huge effort, right? Like, who's going to take on the responsibility for screening the population as a whole, like the whole health department? Hard to imagine, right? Deploying prevention across an entire population, super tough to do. Even those who don't qualify for Medicaid in Texas, that's 100,000 lives in this county. That's a lot of work to do. So the provocation is this: can we start inside out? People are presenting at specialty clinics with musculoskeletal issues, for example, right? And we built we disavowed the fee-for-service model for the safety net here. We deployed a strictly value-based care model by design and in model. And we recognize that the first time we meet most of these people is when they present with a specialty care issue, oftentimes musculoskeletal orthopedic issue. Why not do the screening there? Not because that's the best place to do it necessarily in the broad scheme of things, right? But it is the first time we're meeting them. And in a fee-for-service system, those people see them as surgery candidates or injection candidates because that's what they get paid for. In ours, we get paid for outcomes, irrespective of what we actually do to them. So we do a really heavy screening at presentation of musculoskeletal. And it turns out we divert 2/3 of the people to physical therapy. We divert 1/4 of people to cognitive behavioral therapy and nutrition change. Only a tiny percentage, I think the market norm is 75% end up with a procedure with an injection or something. Less than 1/5 of ours end up with an injection. And it's not that people who need surgery don't get surgery. People who need surgery get it. But it turns out, like, if you design the system well and you screen appropriately, you can actually back out a lot of the things that don't need that specialty care.
So let me dig into that. So I present with a back injury or knee or whatever. Do you have different staff on intake that
Yes.
are obviously trained differently? Because that's a pretty interesting model, if so.
Yeah, that's right. And so that's inherently what's different is when you come, we have a multi-provider model. You are just likely to see an MA, a nurse, or a physician as you are to see a mental health professional, a financial counselor, a nutrition or rehab, or physical therapy. And because we're paid on outcome, our teams work as teams. They're measured and paid on outcomes as a team, not as individuals. So it de-incentivizes the individual behavior you see in practitioners traditionally in the fee-for-service system to optimize the utilization of their service, right? And so it's a remarkably different model with remarkably different outcomes, remarkably different in cost savings. And you know, there was a waiting list. If you want to see an orthopedic surgeon in Travis County and you were in the safety net, the waiting list was something like 400 days before we arrived. And if you actually do thoughtful, intentional screening, you can get, it's down to below 2 weeks, and it's stayed that way for the last 5 years here for the safety net population.
Yeah, and it's interesting that instead of sort of saying when I started the question, we should focus on adding prevention and screening, adding resources. You're more saying, no, let's integrate it, and everyone is doing prevention and screening as part of their intake. That's right, Vic. But the really important aspect, which I know you appreciate, is the payment incentives have to align. Otherwise, the system will behave in the way that makes it the most money. Yeah, and I think it's important to you pointed out, but I'll just emphasize it. Dell Medical is designed as a 100% value-based care provider. There aren't many, there might not be any other health systems that are 100% like that. So everyone is sort of 1 foot in each boat, and that can be a challenge operationally. It is a challenge. Absolutely. Yeah. I mean, we're working through the transitional business model, right? Because most payers right now have a schedule that is a fee-for-service schedule. We have to work with them to remanage that. Yeah. Let me circle back around to Mike. So Mike, on the employer side, you have aligned interests there in the employer base. How do you think about maybe weaving in prevention and screening into the care model?
Well, what Stacey was talking about sounded very attractive. I was writing it down. I'm going, boy, we got to get Stacey to talk about what they're doing. Honestly, I don't think that's the level of conversation. And one of the challenges employers have more generally, particularly big national or global employers, is their employees are spread across the country. And so they can't think in terms of just one location. They can think of their biggest locations. And oftentimes when they're thinking of their biggest locations, they're thinking about some sort of partners in those locations if they're going in that direction. The alternative is to have something that can apply across the country. And that's where some of the technology solutions or virtual solutions have some appeal, because they can have one solution across their entire population. But what Stacey was describing, I think, is attractive and very innovative, and it's a way to think more holistically and with a longitudinal view about the individual, not about the issue at hand. Yeah, what's incredible about Dell Medical is it's probably where the country will be in 10 years, Stacey, or 15 years. So it's like a window into the future, but we have to get the rest of the country there quickly. If we can. Yeah, we had hoped 5, but I think you're right. It's further closer. It keeps being 5 years away. It was 5 years away 5 years ago, and it's 5 years away now. Okay, well, Steve, let's go to the last section, because I know we're running late on time, and then we can have a catch-all at the end, maybe.
Yeah, and if anybody does have some questions are showing up, we're trying to take advantage of them, because we're not going to have time to do separate Q&A. So the last topic, and certainly not the least topic, is behavioral health and behavior change. And for the sake of time, we'll focus primarily on behavioral health. But like health equity, behavioral health and mental health are also finally getting a lot of attention. Behavioral health has often been seen as a silo in healthcare, where there's now a clear recognition that it's an underlying component of health across the board. We're facing a critical shortage of behavioral health professionals. Access and cost are incredibly challenging issues. And so would love to hear from your perspective. And Mike, I'll start with you on this one, since you and I actually were originally connected because of behavioral health challenges. And I just want to point out too that I think you have taken this on as a primary issue with employers, which I think is incredibly important. So give us your perspective, please.
Yeah, employers are kind of all in on behavioral health. I mean, they know the impact of behavioral health on their employees, the well-being of the employees' families, and that, of course, affects their employees. They know the issues around cost offsets. If you spend more and you treat behavioral health, there's lower other costs as well, and productivity and all that. So they're in, and the pandemic, of course, has raised even that awareness even higher and commitment even higher, and a lot of it has been focused very appropriately so on the environment that they're dealing with their employees, how the supervisor relationship, the connectivity, the issues around flexibility, et cetera, et cetera, et cetera. And all of that, I think, is really good. I think 5 years ago, even, I think we were playing kind of defense with mental health, essentially treating it if it showed up, and not really being proactive in terms of assessing and early intervention with behavioral health. So all of that is good news, and a lot of the issues around stigma and all that, there's been a lot of investment by employers to normalize and get that in. So the good news is I think employers are on board and are on the team. The bad news, I think, is the system is broke as heck, right? I mean, it is a hugely concerning lack of access within the system. If you talk about equity, nothing has more inequitable access than mental health, because the rich can get access by going on a network and everybody else can't. And that's a problem. So from our standpoint, looking forward, we need to deal with the access and the quality issues. The access through networks, yes. Access through telebehavioral health, big explosion during COVID. Access through primary care, integrating behavioral health into primary care, but also quality, because I think we need to be more disciplined in how we're providing the care, using measurement-based care to assess early, right? Identify early, but also to monitor progress, because there's a lot of variation in the efficacy of treatment. And unless you're monitoring the progress with discipline, you're going to miss the need to pivot and do something different if it's not working. So there's a lot of work to be done here. And it's a major, major focus for us at the National Alliance. But frankly, I think every employer in the country, this is one of the highest things on their list.
Yeah, I couldn't agree more. In fact, just this morning, there was a McKinsey poll that came out that 37% of Americans were either diagnosed with mental health issues or sought mental health treatment. And the follow-up on that was that the vast majority of people who are not seeking employment today in such an environment where employers are looking for employees, a lot of it has to do with either physical or mental health challenges. So that that stands in the way of so many different other downstream issues. I'm going to ask Stacey and Tom, and I'll go to Stacey first, and then Tom, to hopefully give us some ideas or some programs they've seen that actually are helping to attack this the specific challenge around mental health access and services. Go ahead, Stacey.
Yeah, I'll start. Some of these themes will reinforce what Mike said, but I'll start with an extreme. And so designers want to utilize the notion of extremes. Like, look at somebody that's sort of far out on the edge of the system, that will reveal the dysfunction that affects the entire system. And again, as an institution that is substantially focused on the safety net and folks who don't have access, right? All you have to do is look at the public mental health system to know how bad a shape they're in, right? So if someone manifests with a mental health breakdown, they end up in one of two places, either in an emergency room in a hospital, hoping that somebody there understands what a mental health emergency looks like, different from a physical health emergency, but more likely than not, and they end up in the back of a police cruiser because they've committed some crime as a function of their decompensation, right? And so neither of those systems really are any good, because they really wait for people to identify in crisis, and they put them in a crisis loop where they're, either interned in a hospital or they put through the criminal justice system, which is no place for them to recover. And fundamentally, what we really do need to think about differently, and some of this is semantics. I kind of abhor the notion of behavioral health. I understand why we use it, but it sort of invokes this idea that the individual, if they could only just manage their behavior better, they'd be better. It's not. It's a dysfunction of an organ, just like a kidney disease is. It's a dysfunction of the brain, right? And that speaks a lot to the stigma and the general inability for us at large in society to intervene. I have a colleague who calls mental health not a casserole disease. And what she means by that is, if you have a loved one, a neighbor who comes back and they had cancer diagnosis, the neighbors show up with a casserole to wish them well. If you come back with someone who's end up in a public mental health system, nobody stops by with a casserole. And that's a lot with stigma, but also all of the symptoms manifest in daily life. We can see them in schools, we can see them in community relations, we can see them at work. How do we elevate our fundamental level of knowledge and intelligence and ability around that collectively, right? Some of that's about reducing stigma, some of it's about education. A lot of it is about stopping talking about it as a thing separate from the rest of medical care.
Thank you. I mean, that could go on for quite a while. Tom, there was a question, so I'll pose this to you, and maybe you can weave this into your overall answer. I was asking, what's the desire to pay individuals for positive health scores? Can you talk about how, specific to behavioral health, how challenging it is as a provider to be able to address this and make real headway with this problem?
Yeah, so happy to think about that a little bit. I will say that behavioral health and access to behavioral health is a major focus here at Independence Blue Cross. Historically, we were like most health plans, is that when the kind of years ago, the whole concept of mental or behavioral health, and as was just mentioned, as actually a disease that needed to be treated rather than just somebody misbehaving or a behavior that needs to be corrected. When we started integrating or creating behavioral health or mental health benefits, we didn't have any either knowledge of how that worked or any capacity to really provide services in that sector. So that's where companies like Magellan and some of these other groups, emerged to. We essentially outsourced our behavioral network to them, and if somebody needed help in that area, they went there. They may have gotten referred over to a physician, or somebody would write a script and say, "Here, go call this person and have a session," and then there was no connectivity back. And I think within the health plan world, the recognition that behavioral issues are a major component, they're a major factor, they're a major driver of physical health costs, is, even when I first got here, into the insurance business, people weren't 100% sure about that. Now that, is taken as a given, that somebody who's got depression issues is probably not likely to take their heart medicine. And as long as they're depressed, they're not going to take it, and they're going to end up in the hospital, with heart attacks and things like that. So, that's become very, very accepted. The big challenge we have, and then going back to this concept of whole person health, is that the two were really considered very separate buckets. So we've undertaken an initiative to integrate behavioral health into that whole person health, that concept of really treating all the aspects of a member's healthcare, not just the physical stuff. And so what we've done, we started with some of our provider partners, but we have been experimenting with integrating behavioral screenings, behavioral evaluations into the primary care relationship. And we pay for that, and then the ability for the provider, for that primary care physician, to really understand where there's an issue. And, again, this isn't a value-based care model. It's really hard to do during a 6-minute, fee-for-service exam, but it becomes an, expected part and a compensated part of that primary care visit. And then being able to make the appropriate referrals. We've had some really nice success with that. We also just announced a relationship with, if you guys are familiar with Quartet. And basically what we're looking to do is expand that relationship so that that primary care physician is really that behavioral assessment and behavioral referral process is integrated into every primary care visit, and then using that to be able to then get people into an appropriate level of care, an appropriate modality of care. We're also in the process of insourcing that behavioral network, so that we actually control it. We, control the incentives, we control, everything about it, and we can manage that data feed so that if a primary care physician makes a referral, they actually get the data back and understand what happened and what needs to be done next. So this is an area I think that's really, really important. I think the whole concept of value-based care is critical in making this happen, because again, the provider, when you look at a provider, they're going to do what they're incented to do, and if they're on the hook and they recognize the link between effective behavioral care and physical health costs, then you get a productive two-way partnership between the behavioral and the physical professional, as opposed to just throwing something over the wall, which is what the current outsource model tends to do. So I don't know if that answered your question, but I know we're running out of time, so I'll stop there.
No, it does. And of course, and I'll turn it over to Vic in just a second. One of the things we're talking about too is how can we have these conversations in a broader format that's not so time restricted and constrained. And so we're thinking about ways to do that, because we've just touched the surface of these topics. And of course, remembering that the reason why the three of you are on is because you're at the forefront of these movements, whereas the vast majority of the system is still lagging behind. But it is really encouraging to know that that movement is being made. And obviously these three topics tie together. So Vic, I'm going to turn it back over to you to wrap things up and take it from there.
Yeah, okay. Thanks, Steve. I agree. I think we were interested in beginning to build a bridge between the industry leaders and what innovators and other entrepreneurs and other investors out in the country are looking to bring to market. And I think that's really an important role for the next few months and years, to try to bring less siloed, let's all sit in one box, and let's more share and really try to help each other get to the right answer, what's needed most quickly. I'll just note that there's lots to talk about. I think, Steve, as you mentioned, Jumpstart and others, we're going to try to bring more of these events to the surface, try to make them different formats, as open and sharing different voices as we can. What I heard today was many kind of threads around maybe three themes, and I probably have missed some, but the first being really trying to understand and get alignment and kind of understand what the individual people in the population are going through. So whether that's a Spanish family thinks about healthcare differently, or an employer group, or a homeless person in Travis County, how can we really think about walking in their shoes and understanding not population health as like a general overarching massive population, but in that population, there's a lot of individual people, and how are they approaching the healthcare system? What can we do to make it easier for them to access? So that was the first thing. The second one, independents was talking about whole person. Stacey was talking about integrated care. There are a lot of threads in the employer side of how do we sort of not have a primary care doc and an orthopedic surgeon and a behavioral health expert and a benefits coordinator doing their thing, but how can we sort of generalize that and have everyone caring for the whole health of this person in an integrated way? That is a challenge to turn our big industry to that integrated approach, but it's what's needed really to figure out there. And then the last is kind of aligning interests, which I think is part and parcel with the first two. You can't align interests until you understand them. And the integration is sort of part of aligning interests. But we need to understand how the individual is approaching this. How is the provider and the clinician incented, the caregiver, and then the payers, the employer and the insurance company. They all need to be aligned to get the same outcome. And unfortunately, in a lot of places, they're not fully aligned. And so it's really our it's our need to try to make them more aligned and move us towards that. So obviously this is probably a 10, 20, 40-hour conversation that we only had 1 hour for. But I really appreciate the panelists, and Steve, thanks for helping me host this. We'll get it recorded, but then we have to host this again and have you all back to continue the discussion. So thanks, everyone.
Thanks, everybody.